morning, everyone. Ladies and gentlemen. This morning we are privileged to hear from Dr. Tom Pearson. Those of you who live at Okamic have probably already met him as he's a resident here. Dr. Pearson is an emeritus professor of epidemiology and medicine, having served for several years at the UF Health Sciences Center, and also as the director of University of Florida's MD PhD program, which has always impressed me. His career focus has been on preventive cardiology at the individual patient as well as community levels, with a research focus on lipid disorders and metabolic syndrome in coronary heart disease. I noticed that the audience is unusually large this morning for 10 o'clock in the morning. Dr. Pearson received his MD, Master of Public Health, and PhD in cardiovascular epidemiology from the Johns Hopkins University, where he also completed residencies. He joined UF Health in 2013 as Executive Vice President for Research and Education after serving as Senior Associate Dean for Clinical Research at the University of Rochester School of Medicine and Dentistry. Please welcome Dr. Pearson. Excuse me.
Morning, and thanks for the nice introduction. And I guess my title has put people off. I have the same talk in about 8 different versions, and but indeed we are going to talk about heart disease. And so the key to audience involvement is to personalize this. And I've been, for all my career, been interested in atherosclerotic heart disease, heart attacks, et cetera. And one of the issues in American populations, particularly anyone over the age of 55, is basically all of you have it. In other words, the atherosclerotic process, if you were, and we've had studies of auto accidents, et cetera, even down into young adults, and the process of atherosclerosis obviously starts kind of after adolescence and then progresses through life. And so the preventive cardiologist wants to slow that process and wants to basically say that this will never have any clinical relevance. But it is interesting to note that this is a ubiquitous disease ever since time, and it was found in Egyptian pharaohs, by the way, and so it's a disease that we can talk about. And I particularly had interest over the years in disparity populations. So that's the title. Okay. So this comes from a paper I wrote for the American College of Cardiology with a wonderful team of people here about precision analytics and prediction, and how you start to use some of the vast data we have to make sure that our practices are as good as they could be. So this is just kind of a whole group of other people that's helped with this research. So I want to talk about 4 things. There's a lot of interest in the genetic code. You'll hear a lot of lectures about that. I want to talk about zip code. And where you live does make a difference. And so what you want to do is say that precision medicine, the right patient getting the right treatment at the right time, and precision public health sets the right community getting the right treatment at the right time. So really address the question, do we have data resources that are required to assess our communities and identify the medical, behavioral, social, and environmental factors that alter that risk? And can we use then precision analytics to develop tools that will address the disparities in these folks so we can improve it and then implement things to reduce the disparities we see? So here's the leading cause of death in the United States since at least 1900. The epidemic of coronary heart disease was the big story of the 20th century. not just because it was increased until 1968, but also that it turned around and reduced, and that reduction was on everybody's list in terms of big stories for the 20th century. This has continued, but what you can see is that not everybody is at the same risk. And you can see that the risk goes from per 100,000 populations, 76 to 546. That's a seven-fold difference in where you live in terms of who dies of heart disease. And so as an epidemiologist, you say, what's going on? You know, this is not a random. Now, you can also see that the distribution isn't random. You see that in the north and west, the lighter blue means less death. In the southeast, what do they call the Ohio River? They call it the coronary valley. And the Mississippi. So in the southeast, you can see a tremendous Florida. Looks like 3 states. You got the bottom that looks like the Southwest. You got the middle that looks like New Jersey. And you got the north, which looks a whole lot like Georgia. So even within one state, you have this tremendous, and obviously this is why us epidemiologists get very interested in this, because the answer is why and what can we do about it on a population basis, okay? Not just necessarily an individual basis. So, so this is why I have continued to be interested in cardiovascular epidemiology. And it's the American Heart Association, American College of Cardiology, the National Heart, Lung, and Blood Institute, where I've gotten my support and funding, and also participated in their programs. And to have that peak come down and continued to come down in the 21st century, and that also is a big story. So, I think some of my cardiology colleagues believe that they're a major impactor on cardiovascular mortality. They're correct. But there is another perspective from a population standpoint, not on an individual standpoint, but a population standpoint. And that is the determinants of health do include medical care. But if you look at the proportion of the variation, your family history and genetics, which you can't change, adds considerable. The biggest one are your personal behaviors, your diet, your exercise, tobacco use, et cetera. And then there are environmental and social factors, again, like that map shows, that also determine who gets heart disease. So one has to do it with this bigger picture, take some of these other things into effect. So precision public health, Maureen Coring was one of my colleagues we worked with at the Centers for Disease Control. Maybe I shouldn't say that word. Anyway, if precision medicine is about providing the right treatment in the right patient at the right time, precision public health can be viewed simply as providing the right intervention in the right population at the right time. So now we're talking about, from some of my background as an internal medicine cardiology physician taking care of individuals, you can talk about the preventive cardiologist as taking care of groups of people, communities, et cetera. So now we can develop precision public health because we have more accurate measures of measuring disease, pathogens and things that cause disease, exposures, behavior, susceptibility, and therefore we can use these to not only assess population health, but to develop policies and targeted programs. So again, we are talking about something that is an active. Oh, okay. We are talking about something that really does have an active base to it. So we've been contributing to the discussion of this. And if you look at that map, what you could look at this is as there's really two kinds of communities. All of the information is out there. All the advisories are out there. But some communities pick them up and run with them, and other communities don't. So you can kind of look at, there's two kinds of communities. There's the early adopter communities. There's the later adopter communities. With the earlier adoptive communities, what we do is collect data and show that this is a health problem. And then we communicate that data to the populations and have them react to it. Their governments, their American Heart Associations, their medical populations. And with this, they have a change in attitudes and participation, leading to behavior change, tobacco, diet, physical activity, which of course has certainly occurred. Risk factors then change, and you have morbidity, mortality change. Again, without necessarily being a clinical issue, it's a population issue. But we have a problem. We have the so-called late adopter communities. And these are classically a number of groups. One would be rural population. One would be lower SES population, poor communities. One would be minority communities. And we always see that the affluent middle class will be leading the charge, and you'll have these people, large groups of people, lagging behind. So here again, with these late adopter communities, we will do surveillance. We will do mass and local media, hopefully tailored to their use. But they may or may not have an attitude of social change. But if we don't do anything, we oftentimes don't progress down to behavior change. So what we have to do is some extra things down here. We need to organize their communities. We need to make sure they have healthcare services, that some of these things can be carried out. And we also oftentimes need to have environmental change to allow the same behavioral change that a well-resourced community would do all by themselves. So this has to do with approaching the program is really what do you have to do in order to get some of these high-risk communities in better shape. So the components of the interventions it starts out with data collection, obviously geography, demography, age, race, ethnicity, and our surveillance, usual morbidity, mortality, the use of healthcare. And so we do have the opportunity to provide these communities with a lot of information, and then what we want to do is make sure they do something with it. What we did in the years I was here on the faculty was we had a great interest in making a public health library guide at the faculty library, where you could get all this data together and someone wouldn't have to go and do all the work we did to pull it all together. So it would be used for whatever people would want. So these are descriptors of data with population and location specificity, the costs of the data that was required to get it and use it, and then provide it to the resource managers at the library. And again, I think that's a very good role for a state university. And here's some of the things you could get from your library guide. And the answer is a ton of stuff. So this is the graduate student's dream, okay? Because what they could do is take all these data, use them for free, and put them together and do a study. And I won't go through all of these, but you get the idea that that this is not a data poor environment, and so the service we provided in terms of these categories, agricultural, environmental, clinical, et cetera, just to bring it together in one place so that people could use whatever data they wanted. And we had a number of partners. Florida obviously has a very mature healthcare system, and there's a lot of potential consumers, and we called this the One Florida Data Trust. So, and various places would have different uses for these, but in any case, it's quite a diverse healthcare system to interact with. So what we wanted to do is identify and characterize the risk of some of these populations. One of the populations that I've particularly had an interest with over the years, starting in Rochester, which had a very large population with this, is the deaf and hard of hearing community. And there is a group of people who particularly are characterized by using American Sign Language. And one of the things that I did in my career is trying to understand their risks and how we could provide better care. The typical interaction with a physician is without an interpreter. They don't know, they can't communicate what they need. The physician can't understand what they want. And so really you don't have the level of healthcare that I think we would all like to see. So to characterize what's going on with them, and then to look at the interventions was part of my large center funding at the University of Rochester. So we did want to identify some of these communities that might be targeted, and the data that you could have would be obviously in the electronic health record, identify people with cases or certain conditions. There were disability-friendly surveys. So with the deaf population, do you know how a lot of health information is collected? Telephone surveys. How effective is that? So the major source of all that data doesn't exist in the deaf community. Just give you an example of the issues, and they deserve the data quality and the usability that everyone else does. So we had a number of American Sign Language interviewers and a variety of things. And then what you could do is take their given where their location, their addresses, link to environmental data. And obviously the other thing that the deaf community really wanted was the dissemination of results. Academia is notorious for going out in communities, collecting all kind of data, using it, writing their papers, getting their grants, and giving it back to the community. And we wanted to make sure we weren't going to be doing that. So again, the population segmentation is to find a high-risk cohort. You have the cases. You can link it to other multi-source data, all sorts of physical, social, and clinical factors. You might want to segment communities by burden of disease and different factors. Some of those could be geographic. Some of those are socioeconomic, et cetera. And then analyze the data to look to see if it gives you any insights into specific disparities and social determinants of health. And then focus your health education and community organization programs on that basis. So this is precision public health. It's not just going out into the evening news and giving an ad to everyone, but to identify the high-risk people and actually give them a message that they can use. So like precision medicine, where we would do a test on you, and if you had something, you'd get a certain brochure or a certain program or a certain drug. This is doing the same thing at the community level. So here's precision medicine. And precision medicine, and I like to think I still see some patients with lipid disorders, and before I gave up my license to come to Florida. So I, even after I was mostly doing academic things, I had a lipid management clinic. And we still do use precision medicine, but it's changed. So precision medicine is the right treatment in the right patient in the right time. And certainly the right patient is a lot more information, because now, particularly electronically, we not only know their medications, sometimes we know some genetic data, metabolic data, otherwise known as blood tests, health records of what they've done before. Some are getting their genomics done, environmental factors asked specifically about that we didn't used to have, obviously their health behaviors and their social situations, and then really use this for early risk prediction, differential diagnosis, and treatment organizations. And so that's the revisitation of the new precision medicine rather than one size fits all. But with the data, we can have some very tailored applications. And so, and I think this is I think one of the good effects of all of the data and information science that we have, and obviously is in the process of getting implemented. Now, the other thing you can do then is identify high-risk patients, but you can also identify high-risk communities. And if you have the good population data, you'll see tremendous heterogeneity in data that are comparable. You obviously have to adjust for age and gender and maybe even a socioeconomic status, but you will find tremendous variations in whatever chronic condition you're looking at. And the answer is, if there really are some disadvantaged questions, why is that? And what do you do about it? Or you just let the curative healthcare system kind of deal with it, which they don't usually do. They'll see the patients, they'll spend a lot more money. It won't be able to treat everybody or save everyone in the case of coronary disease. And so there needs to be this public health cap in order to really optimize what you're doing. And you know, if you look across the communities in the United States, there are places that have had disasters. There are food deserts. You know what a food desert is, and that is you can't really go out and find a healthy place to eat. I think every place has gotten better, but I think they still exist. I won't pick any communities to illustrate that, but there obviously are groups with large disparities in resources, income. There are quite a variation in health coverage in terms of physician access. I think Florida isn't too bad, but I think certainly, particularly in rural areas, inner city areas, you've got huge gaps in terms of health coverage. There are places with pollution. I think for cardiovascular disease, particularly air pollution, is an issue. You've got racial disparities. You have racial heterogeneous populations, and oftentimes in those populations, you'll see great differences. And this isn't just the racial, but there's also ethnic, other kinds of disparities that also. The increased vector-borne diseases, I guess they put that on Florida for a reason, but some of those, I guess, would have an impact as well. Oops. So this is just, I'm not going to go through this, but just the comment is that the social scientists and the psychologists, et cetera, have kind of divided this into issues at the individual relationship, that is family, schools, et cetera, community and society levels, and then looked at the data that are available to describe, and you can see a lot of areas here where you'd be very interested in the data for a whole variety of things. Again, food deserts, gun control, employment records. So the point is that while still maintaining privacy, there is an opportunity for people interested in preventive public health to do a good job in identifying the neediest people. So what you'd like to do is, in precision medicine, but you have a person with a condition, and you do their genome, and that informs the treatment and hopefully improves the health outcomes. That's called precision medicine. And the whole point of this talk is that there's another approach, and that is to do the same thing at the community level, and that's precision public health. This is a way too complicated slide, but the point is that those of us geeks like to develop mathematical models in which you can sort this all out and put all the equations together. And when you do so, you see that quite a bit of the variation from one community to the next can be explained by things, and some of those things are modifiable. And so the question is, and the same thing is treating a patient, treat them this way or treating that way, you would have information to treat a community this way or that way. So, so what we do with our research studies is really to ask whether a tool, like an intervention, is effective in typical populations. We look for association, collaboration, and reclassification in terms of what that tool does. Can you modify it and tailor it to specific communities? And is the modified tool effective in persons with communities? So that's the whole research basis for not us inflecting the entire population with interventions that may or may not work, but testing them out before we do. So the implementation strategy, and this is implementation science working group that I chaired for the the National Heart, Lung, and Blood Institute, is way too complicated. But the point is simply that there are things you can do with social, cultural, and physical environments, and with our clinical practice guidelines and implementing them. You may need to deal with some issues at the policy level, national policy, like funding and accreditation and a variety of things, at the provider level and at the patient level. And so when we then start looking at working with clinical guidelines, which affect a lot of people, we have to look at some of these other issues at the clinical institution level, at the policy level, and at the patient level. But just to say is that you can organize things that are effective. So essentially with precision medicine, what you have is a lot of data. You have genetics, you have some physiology data like testing data. You have other kinds of things. You have your genomics, you have your healthcare claims, you have environmental data, and you can put that all together and analyze them and really develop a decision support tool so that you can inform caregivers, patients, and clinicians about how they can take a better care of their individual patients. Precision public health, also obviously at the community level, you'd have the electronic health record data, you'd have social determinants, the social characteristics of communities, you have individuals' behaviors and other environmental factors, put those all together and come up with surveillance and health education policies and supports and use that to affect health services, community knowledge, and community programs. And that's what implementation science is. So and so just what this has to do is that these can really be merged together. That's basically what this says, is that what perhaps individual clinicians need to be aware of the variety of community resources and things they have for their patients, and obviously public health physicians and providers need to work with individual clinicians. And that's why we work with the American College of Cardiology, we work with the American Heart Association, we work with a variety of groups so that the precision medicine, the precision health can really be brought together for everybody's benefit. So we do have some challenges, first of all, is there's extensive amounts of data and types of data available. And do they include some of our subgroups? Do they include rural populations? Do they include disabled people? Do they include racial? And so we have to be kind of diligent to make sure that these people are included. Otherwise, they kind of get left out of the action. Can interventions really reduce risk? Proven interventions that are proven to reduce risk, can they be implemented in these persons or communities? So in the deaf community, you can imagine the challenges. You know, are you going to really put a radio ad in, even television, without closed captioning? A whole variety of things. You're going to leave that whole group of people out and depend on possibly less proven and useful things. So, you know, this inclusiveness idea is very important. And also the analytic tools, so they function in these persons with communities. Do we really, for example, a risk assessment, just in a person who's blind or deaf, are we really getting the information from them so that we can assess their personal risk, to say nothing about the risk of their community? So there are, and so some of the challenges that we had relative to doing this at a university-based program was to think about those things. So those are my comments today. It's, but again, it's precision public health. And I think everybody here has a mindset of individual medicine. And I think the teaching lesson today is there's another level. And the level has to do with both in terms of professional services, as well as health information, as well as environmental. There's a whole nother area of precision public health that we need to think about. And that's kind of where some of my research was, heavily data oriented. But we have done, for example, community interventions. We've intervened in 2 rural counties in upstate New York for a period of over 10 years. These were the ones with the highest heart disease rates. And when we were done, they were the lowest 5. 90,000 people living in 2 rural populations who now had smoking. They had, none of their kids were buying cigarettes, for example. We snuffed that out. And there were places to walk. There were screening programs. So we get this kind of, oh, I can't do anything about that. This issue is too big. We took exception to that if you organize things. And then what you had, therefore, is fewer people going to coronary care units, fewer people going to emergency rooms, fewer people obviously needing care for the diseases that have cropped up. And the problem is to sort all that out and show that all fits is extremely complicated, as you probably got an idea. But that's precision public health. So I'm glad we could introduce that to you.
I see one question already.
In terms of medical research, to what extent do HIPAA regulations prohibit you from gathering the data that would be necessary to be even more precise?
I think that is always something you have to work through. I think generally, I think, well, I haven't done any HIPAA things in a while. A lot of the things we do, we would collect, we identify people in clinics and not use their HIPAA data, but rather collect our own. And it might be different quality. But so when you go into a medical record, you are really at risk for who knows. And the physician might be busy that day and forgot to talk about smoking, and so generally, I think we've had more of an idea of getting the primary data from ourselves, but using populations that might be in terms of age and location, et cetera, that we would be interested in studying.
Yes, thank you for your informative presentation. You mentioned that around 1968 was a turning point for the decreasing mortality rate from cardiovascular disease. And would that be at a time when statins were starting to be available? No, the statins didn't come for about 10, 15 years later. So
well, let's talk about that. This was certainly, I mean, this was well before my time, but this was the great epidemic of the 20th century. We had a president who died of stroke. Franklin Delano Roosevelt died in office of a stroke. We had a president who had a myocardial infarction in office. His name was Eisenhower. And it tended to start getting people's attention. But what was really attention is the president of your company just dropped dead. Your uncle, who's the same age as your father, just dropped dead. And there's 20% of people found out they had heart disease by dying suddenly. Another 40% had myocardial infarctions, and only about 20% came up with just chest pain without any damage. So the idea for preventive cardiology in general was to really reduce that mortality. And this is where internal defibrillators came from, and defibrillation, and all of those inventions that really were inventions and had to be perfected, but then also got into, every ambulance has a defibrillator in the whole country. I mean, what a remarkable kind of thing. So the idea, the dissemination of this took some time, but the 68 was the peak in terms of age-adjusted mortality, and then it has come down, and that coming down in the end of the 20th century and continuing into the 21st century was everybody's top 10 stories. And of course, with us looking at that, and we ask who's left out, and the problem is we find a lot of people left out.
I'm interested in community resistance to some of the recommendations that are made, and what have you found?
What we found was giving people a menu and letting them choose was much better than say, here it is, take it or leave it. And so you would have a variety of things in which you could do things with nutrition. Early on, tobacco laws got a lot easier because the muscle started coming in from the state, so what do you do when you go out in the community and there's all these quick stops, these little things. And it turns out in rural communities, these are really important. This is where people really do their grocery shopping, these are, and before, this was in New York State before we did that, the tobacco was out on the shelf. But it actually wasn't out on the shelf because the tobacco companies, literally, and this is true, we verified all this, they would go to the store owner and say, well, we would like, why don't you get this bin of tobacco and put it over there in the corner? And so it's easy for people to take. You know who the people are? Teenagers. They were basically teaching shoplifting. We did this, we came across it. This is honest to God, something we dealt with in upstate New York. And so what happened at the state level, we obviously, not alone, of course, pushed for where the cigarettes now. They're behind the counter. You can't even touch a pack, at least in New York, without somebody asking you what your age is. So there's a variety of things you can do, and I'm sure there was resistance to some of those. So getting to your question, there's some things that you can make sure it's so logical that they'll do it. Others, you can get some other help to do it. Or the other thing is you go at a legal level, policy level, and basically say that it must be done. So it's an implementation kind of set of challenges.
I'm curious if you think this new emphasis on MAHA to be healthy, to do away with some of the snack foods and to take them away from SNAP and to sort of encourage people to eat healthier, if you think that's going to work.
Well, that's a whole complicated issue. I mean, we've been encouraging that forever. Nutrition is really quite an interesting thing because there are populations in which that bag of Fritos is their daily diet. And so you get kind of a little anxious about things. But some of those kind of sounding onerous rules, I guess my point is let's wait and see what happens. Because sometimes when you put in a rule, you develop an underground economy. This has occurred with a number of things, tobacco including, and it hasn't been as effective on the population basis in general. But I'd have to say I'd be delighted if all my quick stops had some nice apples and whole grain cookies and things like that didn't have your daily allotment of sodium in them. So it's a process. The other thing is, of course, the American taste bud, and those requiring salty, sweet snacks is probably well established by the age of 3. So that's the other issues you have to deal with. So.
You've been talking about extensive data and data analysis. To what extent have you used or do you anticipate the use of AI in assessing this information and figuring out how to use it?
That's a really good question. I mean, it's been a few years since I've been doing that and talking with state health departments, et cetera. So I don't know the answer to the question. It's a great question. And clearly, there are some hints, though, and that is that the academic, the university community, obviously, had developed many of those multivariate adjustment procedures, risk stratification, and a lot of the biostatistics and quantitative analysis things have come from universities and are very high quality. And AI is essentially the same in terms of some of the decision rules, et cetera. So the question is this going to become a gold standard for when you get that number, you know where it came from? Because I think that's the question. We have to be trusting of those numbers. And for it to say if it comes out of AI, it's the right number, I think that's the question. That's the question. And many of these things you can track back and say, well, they left out African American, or they left out, poor people, or, sorry. And so then obviously we get concerned.
What's your definition of persons with disability? Who are these people?
That's a broad definition. Actually, there's a federal definition and there's obviously different kinds of disability. There's physical disabilities, there's hearing, a site. Those are really documented in terms of who can apply for certain funds. So I think they're kind of individualized by that. And of course, there's these gray zones of people with, hearing abnormalities, but that aren't basically, where are they? And that's kind of your question is how can you determine whether or not you might be eligible?
Well, there's hearing, there's vision, there's also cognitive capability.
Absolutely.
So if indeed the intelligence is distributed in a bell-shaped curve, half the population is below 100 IQ. So, and there's also the disabled population that hasn't been educated,
Right.
has not had an adequate even elementary school education. One of the populations that I didn't see defined is the indigenous people.
Mm-hmm.
And I wondered how many of those red spots on your map were so-called Indian reservations.
I think we're very aware of, they have several issues. Number one, they're oftentimes rural. So if you've got rural populations, you probably also have issues in indigenous populations of thinly, well-distributed, et cetera. Obviously, there is some organization, the Indian Health Service. Indian Health Service has had a long and I think quite good experience, but also there's plenty of stories about issues, et cetera. So I think and all of those do have definitions of eligible populations that I'm not going to be able to recite to you, but the point is that it gets to a point of advocacy and that these groups, so I was largely working with a deaf and hard of hearing group. And one of the interests we had there was the advocacy so that the resources would be available. And there's a variety of, obviously, technologies that could make their life a lot better, and then why aren't we using them? Mm-hmm. And so that was a reasonable example for all disabled groups who traditionally had been really left out. And we had data about, mammogram rates and colon cancer screening, et cetera. All of that was, rock bottom in our deaf community in Monroe County, New York.
Yeah. We have a Zoom question. To what extent has the average cardiac or other physicians accepted and now utilized precision medicine in their practice?
It's a great question. I think it's creeping on there, and the way it's getting on there is via a variety of guidelines and recommendations from the major societies. So if you were to dissect, say, the American College of Cardiology guidelines for certain things, some of which I've participated in, they would be precision data based. And a lot of, for example, there'd be tools that would help the physician to look at risks. So here you've got high, medium, low risk. And so you have a score and you can say this person's high risk and perhaps should have some other attention. So there has been, I think the whole idea of preventive cardiology, one of the things is to make it easier for persons practicing medicine and cardiology to be able to identify high-risk people and to get them into a preventive program rather than waiting for them to have a heart attack so you could send them to the cardiac cath lab or put them on four different medicines. So that was kind of the whole idea of where this came from in the late 1960s from the National Heart, Lung, and Blood Institute, and certainly validated by the American College of Cardiology.
Speaking of populations not addressed, I've read that until maybe the last 20 years, the data that physicians had was based on tests, studies with male patients, leaving women out, especially in cardiac care. apparently women with heart disease present different symptoms than men do. So this is a male-dominated profession
Well, I think
looking
that
after themselves.
I've actually participated in those discussions, and I agree with everything you said. And that's, I think maybe 20 years ago, that was an enormous problem. But there's a couple of things made a great difference. One was training a lot of women cardiologists.
I'm sorry, say what?
Training women cardiologists.
Yes.
And so I worked for one for years, and you made very sure that there wasn't kind of a double standard. I think that was one thing. And the other thing was the rewriting in the American College of Cardiology, which was certainly a male-dominated organization at the beginning, obviously had gotten much more gender aware. In many places had symposia and a variety of other things, as well as special documents. I think the American Heart Association had one or two or three of them in terms of cardiology issues for women. The chest pain thing is very interesting because, the first thing the idea of the elephant on the chest, that's a male thing. And so what you learn very quickly as you're in your training, there's, this lady's coming in with shoulder pain or pain in the back. And at least where I trained at Johns Hopkins, you'd be in bad shape if you ignored that. because the people were very cognizant. It's called atypical chest pain, which is maybe even a sexist kind of thing. But I think that recognition came up early in terms of increasing cases of cardiovascular disease presentation and acknowledging that the percentage and the pattern in men wasn't replicated in women. That's probably about 20 years ago, but it certainly had to happen because there was a period in which the wrong model was used.
Well, that misdiagnosis isn't just limited to women, for example,
Oh, no.
because I had a friend who had pain under his right shoulder blade in the back. His physicians at the University of Massachusetts, not at Mass General, never did an EKG. They treated it as muscle soreness, and the pain developed after he'd been exercising. And this went on for years.
Yeah. You could easily come up with a lot of those stories, and it has to do with the emergency medicine crush of people and, and doing their things. I think maybe if I'd like to suggest where the problem was there, and the problem is that our primary care system isn't exactly intact. And if they had a physician who knew this person for 20 years and then he comes in and said, I'm having this back pain, I think you might have a little different because that person, is very well known. And we've had many examples of that.
Tom, very often at this age, you hear a lot of people say, I've lived this long with what my habits and what I'm eating and with or without exercise or whatever. How much emphasis is placed on the age factor? And are you leaning more towards educating younger people to make them feel that when they get to this age, that what they're doing or not doing is important?
I think if you look back, I've been at this since, I did my PhD on risk factors I had 1,000 patients who underwent coronary arteriogram, and we looked at their risk factors in the late 1970s. So we've had a view of this. And about 25% of my patients getting catheterization were women. So they weren't being left out even for that kind of entry test that was at the time. So I think there's been a lot of interest in taking into account gender in a variety of things, both treatment and diagnosis and understanding. And certainly the atypical presentation of coronary pain in women is much discussed and certainly not a new topic. So, but I think that there, again, I think it has to do with, oftentimes, I think the lesion there is having a primary care provider who knows somebody very well, and if something's not going well, there will be a sensitivity to a variety of things that won't occur in the emergency room. I think that's kind of the issue.
I'm just curious, what role, if any, did politics or DEI or wokeism have in your studies? Was there any topics that were off limits? Were there topics that you felt would affect certain or would insult certain groups and therefore you left them out? Or
well, the early studies were clearly, a lot of the early studies were occupational studies, bankers. There was a Minnesota businessman study. Some of these early observational studies, guess who that was? Women came up recently, and a lot of the clinical trials of PCO, we're only going to study men because there aren't enough events in women. That's a stupid thing to say. I mean, all you need to do is pick higher risk women and study them the same way. So, certainly I think by the time I was doing this in the 1970s, there was a great deal of interest in coronary disease in women. I don't, in my practice and certainly in the practices I had at Johns Hopkins, Columbia affiliated hospital in New York and University of Rochester, I really didn't. I thought everybody had pretty good access. But it was an earlier problem, there's no question. All the earlier studies were done on males. Again, all these occupational groups and firemen and a whole variety of things. Well, that's something we got involved with. I worked very closely with Meharry Medical College in Nashville, and we had a parallel study. We had a white cohort of physicians, and they had a black cohort of physicians that have been followed for years, mostly with cardiac endpoints. And we thought that this was a huge issue, and so these were all the same education and occupation. They were all doctors. And so you had a racial, the social economic equality from there, and following those cohorts forward did show some differences in presentation. The African-American physicians had a lot more sudden death. In other words, of all the cases coming in, there were a lot more of them that, had sudden cardiac death. And so that would change your feeling in terms of what you do with prevention, because the variety of things. So there's a variety of subtle things that had to do with human biology, and that should add to the information you have so you can take the best care of it.
Social media use is going out and growing exponentially. But there's a lot of information shared on social media that's incorrect, or at least the study says incorrect. What is the medical profession thinking about and doing to maybe counter some of this incorrect information?
Well, the question, maybe if I could, David, rephrase your question. What is the best use of precious dollars is to debate these people who are saying that, apricot pits, will now prevent your coronary disease, or versus a solid diet that says, if you're above 65, these are the issues you should be talking about. So it really has to do with some limit on the ammunition we have, and to use it well. But there's if you want to go, Google the right thing, you can come up with the most amazing crap you've ever, and my juice will prevent everything, and so that's a mess.
One of my specialists said, "Don't believe anything you find on the web."
That's right.
But if you're going to the Mayo Clinic website,
That's right.
Okay.
Yeah, there have been, Mayo's done a good job with that, and they obviously have, but there's some other ones as well. The specialty societies, I think certainly the American Heart has got some nice nutrition program. I've worked with them and produced some things for them over the years.
okay. One more question. We have come to the end of our time here.
So when you Google something now, the first thing that comes up at the top is AI. There's never a source. There's never an attribution. Some of it seems to be pretty darn good, but I always scroll down to find a more legitimate source, especially on a health issue. So who's going to police that? Because people are going to look and say, oh, AI says.
Well, I think AI is probably the fastest jargonized term I've ever seen. In other words, what AI is a variety of statistical techniques that you can use on God knows what kind of data to come up with an answer. And a lot of these things will always come up with an answer. That doesn't necessarily mean it's the right answer for a variety of reasons. And so certainly my colleagues and I would never depend on one clinical trial, depend on one observational study. All of these things which would have a lot of vagaries that could mean that they're wrong. And you can list a whole bunch of historical examples of this. What they said was because of this and that, and has nothing to do with you. And so I think that's the concern, is AI has been raised to some kind of an exalted, this is the answer. I'm not saying it's not useful, because the ability to bring all these kinds of data in together and it has but what the statistician would really want to do is say, okay, what did they actually do? What was the data sets that they used? What were the analytics that they put it? And it's all a black box. And so the rules, GIGO, the rules, GIGO, garbage in, garbage out.
Yeah.
So that's what we have to remember.
Thank you so much, Dr. Pearson.
Thank you.
Very good.